Wow, this is a great group. I speak and everyone gets quiet. So that needs to translate to my students. When I do this, they just keep talking, you know? So, well, welcome to the second session of the technologist section. This is what I call a packed room. We're going to have 5 speakers for about 15 minutes each. That may go over slightly. Not to worry, we will get out of here on time. We'll kind of keep that schedule running. A couple of reminders. If you can please silence your phone or turn them off. It does get disruptive. And we are recording the session, so that ringtone kind of makes it a little bit more pronounced than what the speakers are actually talking about. If you've not had a chance, you've probably heard this a couple of times before, to please download the app. And several things that you can kind of do in the app. You're able to refresh that app, which I would encourage you to do as new things get added, particularly around the speaker's notes and presentation that they're doing with that. The barcode or QR reader here, you only need to scan that once in this session. Even though this will show up multiple times, you only need to scan this once. You can do this now in between sessions or at the end of the session with that. In order to receive CME points, you must confirm your participation. Again, that's going to be through the QR reader with that. At the end of the session, there will be afternoon tea in the exhibit hall. And also you can have, don't forget to sign up on the wall for the WorldFed meeting as a friend of that. I'm going to introduce all the speakers at once because it is 15 minutes per talk. It may just be a little bit easier and a little bit of a better flow versus me getting up each time in between the speakers. I am David Gilmore. For the ones that don't know me, I will be chairing this session. And today with us, we're going to be talking about what are the new technologies in nuclear medicine, particularly what's new in SPECT-CT. With Dr. Peter Kench at first. Then we're going to go to artifacts of SPECT-CT. That's with Dr. Darren O'Keefe, followed by renals with Bridget Chappell. Then SPECT-CT and lymphos, and that's with Dr. Kevin London. And then finally, new applications for VQ imaging with Dr. Elizabeth Bailey. Again, we will try to finish the session with panel discussion depending on how much time we have after each speaker with that.
Right, I was asked to talk about SPECT and SPECT-CT artifacts, and I titled it the old and new artifacts of SPECT-CT because some of these have been around for quite some time now, and some of them are a little bit more recent when we introduced CT into our acquisition process. Oops, sorry, wrong way. So I'm just going to talk 15 minutes, haven't got very long. I'm just going to talk about 4 main causes of SPECT-CT artifacts. I'd like to talk about all the others, but we'll be there for the rest of the afternoon, I think. Just to acknowledge a few people that helped out, particularly the people at Christchurch Hospital with some of the images. And there's some great reference material around as well. The IEA Atlas of Quality Control for Scintillation Camera Systems. It's got artifacts in it, and I've got some material from the DAT training program as well. I've just put some references in there because I'm going to be quickly citing them as I go through. I have a disclosure. All the equipment we've got in Nuclear Medicine Department of Christchurch Hospital, Siemens imaging equipment, so there's an inherent bias there in the way I'm going to present things. I don't have any financial relationship with any of the vendors, so please excuse that slight bias perhaps. And I'm also chair of the Technical Standards Committee for the ANZ SNM, so at various times I'm going to wave the little hat of quality control is important. Hopefully I'm talking to an audience that's already converted in nuclear medicine. Quality control, as you know, is vitally important. Not going to talk about some things, just wanted to establish a little bit of common ground, going to ignore some of the physiological factors and radiopharmaceutical distribution artifacts you can get. Some of them are quite impressive, of course, and I'm just going to assume not dynamic imaging, it's just a constant fixed radiopharmaceutical distribution. That's where I have to go from in that period of time. Ignoring contamination artifacts like the one on the right for urine, just talking about technetium, just talking about parallel whole collimators, just your routine imaging. Also assume that the SPECT and CT parameters have already been established. They're optimized, not going to go down that path a little bit, but mostly that's already been taken care of. So that's where we stand. Also, I assume common ground, if you've got a SPECT CT system, you're looking after your CT. The quality control in CT, routine stuff, isn't particularly difficult. just going to assume that that's all been done, otherwise we'll be talking forever about some of the CT artifacts that get introduced into SPECT CT imaging. So beam hardening, for example, where the attenuation correction becomes important, and ring artifacts. You've got to make sure you've done all your ear calibrations, etc. So I don't want to see any imaging like this. Okay. Just also a reminder, we still do talk about filtered back projection because it gets the basic ideas in our head about the geometries and things involved. So we've got projection data set, we get sinograms from that, we're going to filter them, we're going to back project across the image, and that's going to generate our transaxial images or our SPECT images. So I'm pretty sure the audience will know all about that. But what I did want to talk about today, and I must apologise in advance to you and spot a few typos and grammatical things as I go through, is what in my head is a mindset of a way of thinking about things. I don't want to be overly simplistic about it, patronisingly oversimplistic. But I just want to introduce a little bit of a different way, physicist way, if you like, of thinking about things without all the formulas and everything. So my mindset is a machine starts out dumb. I know we got sophisticated, we pay a lot of money for SPECT CT imaging equipment or SPECT imaging equipment, but really at its default it's actually quite a dumb system until we start introducing information into it. And still we introduce information, for example, about the geometry, introduce information about the projection data sets. That's all got to be done. If the information isn't there, we've got to somehow try and generate it through some sort of automatic correction processes or calibrations that we introduce into the system, or we've got to override it manually with our human intervention. So, for example, I'm a physicist. I can't take pictures of patients. I've got pictures of phantoms. Okay, so this is my projection data set. So, for example, if I muck it up and my system geometry doesn't align with the actual centre rotation of the gamma camera system itself, then it introduces a problem that needs to be taken care of. And you'll all be familiar with the necessity for centre rotation corrections. So this is a Siemens system doing a multi-head registration as well as a centre rotation calibration, and also checking the tilt of the detectors as well. So if we get it wrong and we reconstruct with a centre rotation that's incorrect, we cause blurring and we get this typical sort of circular artifacts that you see with centre rotation problems. And this is a line source showing if you've got a 1 pixel or 0 pixel offset versus 0.5, 1 and 2.5, things start to really blur. I'm sure you've seen that when you've done your sort of practicals. Of course, patients don't tend to be line sources. It doesn't work terribly well, but we can actually look, for example, at cardiac imaging, what the effect is of introducing a centre of rotation problem. You see across the top is the data that we've got that's nicely corrected. If we have centre of rotation errors, it goes out completely. Okay, so what we've got in this situation is we've got a sort of like comet's tail effect. And the problem that can arise is that it's not consistent across the whole of the myocardium. Depending on where the ring artifact, the artifact that you're getting from centre rotation arises, it can cause increases in some areas of the myocardium, it can cause decreases in other areas of the myocardium. And you can get some interesting effects from that. Also, if you look at brains, it becomes a bit more obvious. 0 offset going right up to 2.5 pixel offset, significant effect upon the brain imaging. So I hope once again, centre rotation, old artifacts that it can generate if it's out. It's quite a well-established calibration requirement for gamma cameras. With new systems, of course, SPECT CT, alignment, of course, becomes very important again. And this is the Siemens system with its sources with contrast and activity in them doing a SPECT CT alignment calibration, because this is what we want. We want to be able to fuse images that are reliably overlaying the nuclear medicine and CT components. Also, if we apply attenuation correction from the CT data, we want to make sure that it is actually in the same geometrical position. So the other thing about the mindset in terms of the dumb system is things can go wrong and the system doesn't know about it. Okay, you can't do calibrations every day. Well, we do some floods and things every day. You can't check extrinsics necessarily every day unless that's the way you do things. You'll always miss out something. So it's just to be mindful that the system doesn't know if, for example, you've got a non-uniformity, extrinsic non-uniformity. I've just given the example here of a cleaner knocking the collimators with a broom. Okay, what it will do is it will generate a poor flood field uniformity, a defect in the images, in one image in this case for a particular collimator. and then that gets back projected into the image, and we end up with an artifact in it. These are your classical ring artifacts arising from uniformity problems. And of course, as you go away from the center of the field of view, out towards the edge, like the image on the right, the artifact moves out away from the center of rotation of the actual gamma camera. To keep in mind, we don't see rings like we used to. We call it a ring artifact, we see semicircles, because it's usually only one detector that's actually affected any longer. What do they mean? What is okay in terms of uniformity? Don't want to go down that, but just to mention there are system uniformity requirements, and this is, for example, myocardial perfusion imaging. One of the groups has released. These are the requirements for standard and preferred for integral uniformity, differential uniformity, etc., for good myocardial perfusion imaging. Clinical perspective, if you look at the impact of that non-uniformity on your myocardial perfusion images, so decent uniformity on the left, introduced non-uniformity on the right of a plus 10% non-uniformity, you can see it has quite a significant effect upon the perfusion and the myocardium. That's 2 down, 2 to go. Okay, I said 4. So motion, been around, been plaguing us since planar. It's not just SPECT specific. It's always been a problem in nuclear medicine imaging because we're taking long acquisition times. So we've got problems of motion, of course, during the SPECT itself, involuntary motion, cardiac motion, respiratory motion. We could use gating, for that situation, some of those involuntary movements. We've got patient movement itself, patient preparation is important, instructions to the patient, and of course the patient comfort. We don't want the patient getting discomfort and moving during the acquisition, and immobilisation becomes quite important as well. I know I'm not telling you things you don't already know. But we've also got the issue of motion between the SPECT and the CT acquisitions, and that can be a little bit more harder to control sometimes. You do have the issues of involuntary motion in terms of breathing during the CT relating to the SPECT acquisition, and also patient movement. If the patient gets a bit of discomfort, you take them out from under the gamma camera, he's sliding into the CT, they jiggle. Okay, or they go, oh, good, that's over. And they do that, and patients have been known to sit up as well. So that presents problems that we have to deal with. Let's just deal with the first and show. In terms of motion during SPECT, can present in different ways. So the myocardial perfusion, this is just a brief example, showing that this is a motion-affected study, but completely different images across the 3 of those. So there are significant challenges with motion. It's sometimes not just going to be simple blurring of your images. It can introduce some serious artifacts and be difficult to detect or impacting upon the image quality. In motion management, we do have tools. You'll all be familiar with the old cine, and the classic cine is a thing you should be looking at to start with. Is my patient jiggling up and down? Are they going around? The eyes are brilliant. They look for motion. Okay, and particularly in the 3D perspective, you're going to pick up things that the computer system won't necessarily pick up, and the eye is very good for doing that. But we have got other tools like the sinogram and the linogram and some of the automatic motion correction systems. These are just examples from Siemens, corrections based on the sinogram and linogram, realigning the data sets in order to be able to improve the image quality and reduce the impact of motion. So it's just an example of that motion correction. On the left is the original image, and of course on the right is the motion corrected image. But don't be overconfident. The systems can actually get it wrong and start out with an image that looks reasonable, does motion correction, and actually makes it worse. So once again, it requires you to be careful in checking the image quality. And I'm going to talk a little bit about patient-related QC. SPECT-CT misregistration is important. Various people have approaches to immobilisation. This was us early on in our SPECT-CT career, duct tape and pieces of various things. I think we've improved a little bit since then. Disappointed in some respects. Hopefully it's starting to improve now. Some of the manufacturers aren't giving immobilisation within their systems much attention. Hopefully that will change in the future. Sometimes that motion is pretty obvious. Okay, in the pelvic SPECT-CT images, you can see pretty clearly you've got misregistration. But when you get to something like a sentinel lymph node, it becomes much more challenging sometimes. For example, the image on the left is really what the surgeon wants to be able to go in and take the sentinel lymph node out with a biopsy. They don't want to have a misregistration and have to go digging down into here. Okay, this is already going to be a bit of a challenge for them. So with that misregistration, it becomes vitally important, and there really aren't a lot of clues in there as to what's going on. So once again, it comes back to you being careful, checking the images. Just to mention, because it is an innovation session, there are some things that are starting to help us. Respiratory motion is a big thing in PET CT imaging, particularly for solitary pulmonary nodules. Motion correction and PET's vitally important, and the lung imaging, well, very important in the lung imaging, I wouldn't say vitally. Is it really much use in SPECT imaging? Well, I didn't think I was going to talk about that until I found this presentation by Michael King looking at 2 centimetre respiratory motion, looking at the image quality, particularly the blurring with the extra cardiac activity, doing a respiratory motion correction for the cardiac scans, and actually being able to separate out that extra cardiac activity. So I think that's something we may see in the future. I know it's not necessarily a lot of lung imaging that we're doing in SPECT imaging, but there are other aspects of the imaging that are affected by respiratory motion. Also, manufacturers are looking at this. They've been doing it for quite some time, but there is a lot of more advanced work going on now. This is an example of the the IR MOCO, I think it's called, by Siemens. They've now patented an algorithm based on a combination of SPECT and CT imaging in order to be able to improve their motion correction. Getting around to the end of it. So attenuation. If you don't know what it is, not what it is, how can you correct for it? It's once again one of those things you have to introduce information somehow into the system. If you get the wrong information introduced, you end up with problems. So of course we try to do that with CT imaging. Oops, sorry, that shouldn't have moved. That was my last one. So classic one, of course, is myocardial perfusion imaging and the breast attenuation and the anterior wall artifact. I was going to say it's unique to women, but these days it's not unique to women, of course. Neither necessarily is a diaphragmatic attenuation. You can get it in females as well, but it tends to be pretty much a male thing of the inferior wall. So how do you cope with those sorts of artifacts of attenuation? You introduce the CT data. Now, I realise we're running out of time, so I'm not going to go into all of that. There's another whole story all by itself. But we essentially are taking the CT data, generating an attenuation correction map, the mu map, and applying that in iterative reconstruction in order to be able to compensate for the attenuation or the non-uniform attenuation in the patient that can't be done with a Chang's algorithm. So I'm just showing here the effect of between stress and rest and the effect of attenuation correction. I was going to do a nice little pause here and wait for someone to spot the obvious peculiarity. So if you look down in these images here between the stress and the rest and the stress and the rest attenuation correction, you don't normally get attenuation correction making the images worse, and substantially worse in this case. To look at it a bit more closely, you can see the stress study here. The rest study is pretty good. The stress study doesn't look quite right, does it? It's bizarre. I can even spot that as a physicist. So we went digging around to try and have a look, and we looked at them. Finally looked at the mu maps, because that isn't a standard thing we bring up on our workflow. You have to actually put it up as a default on your workflow to review the mu map, and we now do, and it's for this reason. So if you look at the mu map, it looks kind of like a CT. It's pretty standard stuff. But if you look at the mu map for the stress study instead of the rest study, does it look a little unusual to you? And this was a glitch in the manufacturer's software, that these images looked fine on the CT, but when it generated the mu map, occasionally it would turn it upside down like this, and was applying the wrong corrections to the wrong parts of the images. So my point with this is check it, and don't always be overconfident that the software that is sometimes dumb is actually doing exactly what you think it's doing. So take-home message, patient-related quality control is vital. Yeah, they have to do it with the patient still on the camera. Maybe you check the SPECT before you go on and do the CT just to see if everything's okay, or at least before the patient leaves the department. You don't want them walking out the door and finding out that there's something wrong with a misregistration that you can't quite correct, or the patient twisted instead of went up and down and your motion correction's got a real problem. Just to finish off, mention the new reconstruction algorithms just to be aware of as well. For example, the Siemens XSPECT system is using the CT data in a different manner with the SPECT data, so there's potential there for new types of artifacts to arise. So it's kind of, I'm not trying to put you off the system, just to be as new manufacturers, or as manufacturers bring in new algorithms, you can actually get new artifacts arising, and you need to work with them to even to discover what some of those are sometimes. This is the XSPECT bone system, of course. So just to summarise, some of the common causes of poor quality imaging and artefacts are your gamma camera uniformity. We still can't get away from that, both intrinsic and your extrinsic. We do a great job sometimes on intrinsic, perhaps not so great on extrinsic. Your detector alignment and detector rotation alignment problems, patient motion, and your SPECT-CT registration, attenuation correction, and a little warning at the bottom there about some potentially less common software glitches. There's a lot we've not discussed, metal artefact reduction artefacts, for example, and the importance of that, high intensity sources in the field of view, scatter, etc., but I hope I've given you a sort of a brief overview of some of the SPECT-CT artefacts to be mindful if you haven't thought about them for a while. Thank you.
Okay, as Bridget comes to the podium, I'd just like to remind for the ones that are in the back, there is quite a few seats still up here in front, so if you would like a seat, feel free to move to the front. All right, Bridget, it's all about you.
Cool, thank you.
Also, apparently Darren was very popular. We had the paparazzi in here, right, with the camera flashing. So, Bridget,
Fantastic.
we'll see if they follow you.
No worries. Today I will be speaking on current applications in renal scintigraphy and GFR. Renal scintigraphy is a constant molecular imaging applications. Methods developed in the 1970s and 80s remain the foundation for modern renal imaging. To recognise what the future advancements can be, it is important to understand the principles that underlie imaging today. So in renal function assessment, radionuclide-based assessment provides important functional information that assists in the diagnosis and management of patients. Current renal applications can be divided into two groups: renal scintigraphy, comprising dynamic imaging, renal function, transplant and diuretic imaging, and static SPECT, cortical imaging. And also there's the in vitro assessment of glomerular filtration rate, or GFR. Current clinical use of renal studies showed that diuretic imaging is the most common study performed in Australia and the US, followed by dynamic imaging, then GFR calculation, with cortical imaging being the fourth most popular. Cortical imaging's primarily paediatric use was confirmed, with 60% of studies performed in patients under 14 years of age. 45% of the US survey respondents performed renal transplant imaging as well. So the range of applications available is due to a combination of the availability of multiple radiopharmaceuticals with differing localisation and clearance methods, and the application of differing imaging techniques. So there's 3 technetium radio-labelled pharmaceuticals that are used for the majority of imaging investigations. DMSA, with its cortical retention, is used in the evaluation of renal morphology via static and SPECT imaging. The glomerular filtration agent DTPA and tubular secreted MAG3 are used in dynamic imaging. DTPA also measures GFR, while MAG3, with its higher extraction fraction, is the first choice for most functional imaging, although its biliary clearance can be problematic in poor function. There also continues to be new agents developed. To evaluate renal function using dynamic imaging, the main indications are in renal, oncology and live donor patients. It's also used to evaluate transplant kidney function for acute tubular necrosis, or ATN, rejection and other complications. And it can also be used to diagnose and assess kidney obstruction. So here is the procedure diagram for imaging, dynamic imaging, for functional and transplant imaging, and it's summarised here. Following suitable patient preparation, the patient is positioned supine and the camera positioned for optimal kidney location. Two-phase dynamics commence at the time of tracer administration. The initial 1-minute vascular phase is followed by a 20 to 30-minute uptake excretion phase. Post-void imaging should be performed. On completion of imaging, processing is also performed. So for dynamic imaging, regions of interest are placed over the kidneys, renal cortices, aorta, bladder as shown here. In transplant imaging, an iliac artery ROI is used to assess for renal perfusion using the Hilson index. To ensure accuracy, ROI modification may be required if the transplant kidney overlies the iliac artery, as seen in this example. Background subtraction is performed using adjacent normal tissue ROIs. Renogram and time activity curves of initial perfusion, the tracer accumulation and clearance are generated, and the quantitation measures of renal function calculated. Depth correction can also be performed in native kidney imaging by various techniques. So renal function, normal renal function is a kidney perfusion occurring within 2 to 3 seconds of the aorta, and peak activity between 3 to 5 minutes. Split renal function should fall between 43 and 57%, and you have an 8 to 10 minute clearance half time and a 20 minute to max ratio of less than 0.3. Whole kidney renograms are shown here. Normal function is in green, with obstruction, number 1. Impaired and severe function are also shown. In transplant imaging, normal function for perfusion is the Hilton index can be used. A low index is good function. Kidney perfusion should be simultaneous to the iliac artery with peak between 3 to 5 minutes and bladder activity occurring 4 to 8 minutes post-injection. Renograms of normal function in green is once again seen. ATN along with impaired and severe renal impairment are also shown. So here is MAG3 renal studies in normal function. So I think apparently I've got to click. It's not working. Sorry, there's supposed to be cines. Oh, there we go. There's your non-functioning kidney. Sorry. Okay. Okay, thanks. All right, so there are your cines of your normal function, your acute tubular necrosis that shows accumulation of tracer, and a non-functioning kidney. Moving on. Here's the cross-sectional SPECT-CT, and the few slices demonstrate function in the inferior pole of a transplant kidney, which is the purple arrow. I won't touch anything. And that wasn't discernible on the planar imaging. The functional native kidney can also be seen, as well as activity in the ureters. So the white arrow there shows the native kidney. In this case, the absent function was actually caused by a superior renal artery occlusion, which was found on Doppler ultrasound after this study was performed. So then from this we move on to dynamic imaging procedures. A diuretic imaging to assess a kidney obstruction can be performed as an adjunct to standard imaging using the F+20 or a standalone F-15 procedure. With the F+20 here in orange, pelvic urine retention can be assessed prior to diuretic administration. If no abnormality is seen, the study can be terminated. Imaging can be performed as one 40-minute continuous acquisition with diuretic imaging at 20 minutes, or it can be 2 separate acquisitions. In the F-15 protocol shown here in purple, the diuretic is injected 15 minutes prior to imaging. The F- study gives better discriminates better between obstructed and non-obstructed kidneys, and is the method recommended when the F-20 study is equivocal. Region of interest analysis, time activity curves and diuretic clearance times are calculated. In diuretic imaging, a T-half less than 10 minutes is normal. A half greater than 20 minutes is abnormal and shows obstruction. The F+20 renogram shown here shows normal. Total and partial obstruction curves in the intermediate equivocal curve range. The cine shows a normal tracer clearance from the left renal pelvis. The cortical imaging procedure is once again summarised. Patients are in doses titrated in paediatric patients according to weight or a nomogram. The patient is injected and imaging commences 3 hours post-injection. Static images are required. In paediatric patients, pinhole collimators can be used to magnify the kidneys. SPECT plus or minus CT imaging is performed. Planar imaging can be processed to calculate split renal function, and depth correction can be calculated in adult patients. It's not necessarily recommended in paediatric procedures. Planar and SPECT imaging are then visually assessed for inflammation, infarct and scarring. So this normal split function is around, once again, in that sort of 45 to 55 zone. Pyelonephritis shows reduced uptake, while the scarring appears as a wedge-shaped defect, similar to it would in a lung scan. So renal imaging considerations. So really, what should we optimise to ensure image quality and accurate results? In patient preparation, your patient should be hydrated to avoid parenchymal tracer retention. Dose extravasation can cause abnormal results due to continued dose absorption, while a full bladder may result in delay in renal pelvis drainage. In scanning, you want the correct camera position to get the right information to do your analysis. Post-void scanning can help to assess renal pelvis retention and drainage. SPECT CT's 3D and anatomical information can assist in the interpretation of images, such as differentiating pathologies from MAG3 biliary excretion and to localised normal and renal urine activity. And in the analysis, you have to have a knowledge of different radiopharmaceuticals patterns, as the same looking image in DTPA versus MAG3 can show very different things. A correct regional ROI placement is important. You want your aorta region above your bifurcation of your kidney renal arteries. In transplants, it's got to be below. The iliac artery has to be below the kidney. In diuretic imaging, renal pelvis ROIs may be more accurate than whole kidney, and transplant patients still may have some native kidney function and urine caused from that in ureters. So we move on to GFR. GFR is used to evaluate renal impairment and chronic glomerulopathies, and also to assess live, donor and oncology patients. Here's two agents are currently used for GFR calculations, and these are summarised here. Technetium DTPA has a small amount of protein binding, but it's good imaging characteristics, allowing for dynamic imaging and dose extravasation assessment through arm imaging. Chromium EDTA has negligible protein binding, but has a long half-life suitable for delayed analysis, but imaging really isn't possible. For GFRs, the patients are once again hydrated. You want their height and weight recorded. You need patent venous access to ensure there's no extravasation of dose. A standard of known tracer amount and the patient dose is prepared. Syringes are measured pre and post injection or preparation to determine the exact amount that's administered, and times once again need to be recorded. Multiple blood samplings are taken, once again with accurate record of times. Samples are then centrifuged. Duplicate plasma and standard aliquots are pipetted, and these are counted in a gamma counter. The results from the counts obtained, results of GFR can be calculated. There's various single and multi-compartmental models that can be used for the calculation of GFR. The slope intercept technique that's discussed here is a single compartment model, and it uses the plasma counts to generate a time activity curve, and from that the plasma T0 counts and a half time are calculated. The plasma volume is then determined from the plasma T0 and the half time, and from that the GFR is calculated. It is then normalised for standard man and expressed in mils per minute per 1.73 metres squared. And that is the standard unit for GFR measurement. So comparisons to eGFR are always in the 1.73 metres squared. Corrections for this technique, single compartment model can also be applied. In adults, a normal GFR is any number, or is a number more than 90, but GFR declines with age. A low GFR is said to be less than 60. Hyperfiltration, which is a marker of early renal damage, is a GFR above 150 mil per minute per 1.73 in adults less than 30 and is above 120 in older patients. So once again, we have particular considerations for GFR. Patient preparation is pretty much the same. Your data recording really needs to be good because your accuracy is critical in getting the right result. You need to record your dose and your standard, your height and your weights and your time, because it's a time activity curve. So we need to know the time that things are done. You need good technique. You need to make sure that your dose is all injected into the vein, that your standard is prepared properly, that there's not too much volume in your standard, your pipetting, you're accurate and precise with your pipetting, and that your data entry is good because, fat fingers and little keys, you can always have typos. And for that reason, we really need to check our results before popping them through for reporting. You want to check if there are any possible errors. If there's any extravasation with technetium DTPA, it's easy, you can do an image. I know some centres use counters to check arms for EDTA. You can also cross-check your references against previous results or eGFR to see whether it matches. It also matches the patient's story as well. And sometimes it's maybe worth checking whether the model matches the patient. If you've got a liver patient who's got a lot of ascites, a single compartment model may not actually be the right choice. So in conclusion, molecular imaging renal investigation, it's not static. It's a modality that continues to change and adapt, even if it is based on things that we did, 30 years ago. So you can say that, and it's only going to change more with advancements in imaging and quantitation. Dynamic SPECT applications could be used in renals. Camera technologies and improved radiopharmaceuticals. PET tracers are also being developed for this kind of stuff as well. And these will further advance renal scintigraphy and to continue to improve the outcomes for the patients. So that's it.
Great. All right, great. So next we'll welcome to the stage Dr. Kevin London. Remember, I told you we're not really behind. We're just using up our panel discussion time as we go along.
Am I allowed to touch the mouse? Sorry. The IT guys do a really good job, thanks. My name's Kevin London, I'm from Sydney, and I work at the Children's Hospital at Westmere, but half-time I work in a private nuclear medicine practice with a vast experience in lymphoscintigraphy, and I'm terrified. Nothing terrifies a physician more than presenting in the technologist track. So lymphatic mapping really goes back over 150 years, and up until relatively recently, the work by Sappi, where he did a fantastic experiment by using a glass pipette that he had stretched while hot to make a very fine needle and then inject mercury into cadavers to try and map the lymphatic pathways from the skin. And as they did in the time, he made these exquisite drawings, although I'm not quite sure exactly how accurately this represented his experiments. However, first of its kind, and really for over 100 years was thought to be the gold standard for lymphatic mapping. And particularly, there was this idea that you didn't get lymphatic pathways crossing the midline. You can see all of the the passageways from the back ending in the midline, which we know is incorrect, and I'm sure everyone realises. So just before I show some cases and talk about how SPECT-CT is important from a physician perspective, a couple of notes that the anatomy of your lymphatic collectors is such that you have these junctions that allow particles to move into the lymphatic capillary. And so the junctions are a finite size mostly, which means the particle size of the colloids that you're injecting are quite important. So if you have a large colloid size, it has difficulty getting into the lymphatic collecting channels, requiring a lot of movement of the limb so that the muscles stretch and twist the lymphatics to open these channels enough to get the colloid in. So antimony sulfide colloid is thought to be one of the better ones because the size is small enough to enter these channels reasonably efficiently, as compared to filtered sulfur colloid, which can yield larger particles that don't pass into the capillaries as efficiently. How is SPECT-CT important from a physician point of view? I thought I'd illustrate it with a couple of axilla sentinel lymph node cases in patients with melanoma. So here's an adult patient, as all of the patients presented in this talk are, with a melanoma being mapped from their wrist. This is the image with the flood source behind to show an outline of the body. That's the injection site, and on part of the early imaging you can see that there's some uptake following the contour of the arm, but then clear uptake within an axillary sentinel node. And in this case there were 2 interval nodes along the brachial region of the arm and an intense right axillary node. In the days before SPECT-CT, there'd be a mark put on the skin and the surgeon would use his trusty gamma camera and go for it. But obviously, SPECT-CT here, as Darren quite eloquently pointed out, you give the surgeon what they want, which is accurate registration between the anatomical and the SPECT to help them plan their surgery. Here's another case. Again, it's a melanoma patient who was injected around the upper arm. Quite faint uptake here. The activity is less intense, could be related to injection factors. However, there are 2 clear sentinel nodes in the axilla, and you can imagine that a surgeon toiling away in the operating room might have trouble finding these, particularly if they're operating some hours after the study to try and find these relatively low-level counts. SPECT-CT, incredibly important for the surgeon to guide their incision as well as the mark on the skin. This is the last axilla case, and I don't have a good flood source backlit image, but this is an injection on the lower back just to the right of midline. So these are the composite dynamic images showing tracer passing through collectors upward and 2 collectors heading downward across the right side of the patient's body. This is an anterior projection, let me get this right, of the thorax and abdomen. That's the injection site shine through, and this is a right axillary sentinel node. That was the terminal point of that channel. And this is an image over the pelvis showing us that these channels descended to sentinel nodes in the right groin. Same patient. Again, you can appreciate that this patient has considerable soft tissue. So putting a mark on the skin is, to guide the surgeon, can be prone to subtle differences in positioning of the patient. Very difficult for a surgeon to track this down. SPECT-CT invaluable for them. Now, the black belt of sentinel lymph node mapping would have to be head and neck. I think we can all appreciate, you're just waiting for it, right? You start the earlies and oh my gosh, there's just tracks everywhere, what's going on? Sometimes referred to as the squid appearance. I think it looks like a squid. Now, this is the last case and I'm almost finished, but it does highlight the vital importance of getting very good early imaging to show channels. This is the dynamic composite image taken from the posterior projection. And we can see quite clearly there are some channels coming down to the left occipital region and to the right occipital region to some sentinel nodes that have been marked in the occipital regions bilaterally. Now, same study, this these images on the left-hand side of your screen are taken right lateral, really right lateral oblique. So we're getting some shine through from those awkward hot nodes on the other side of the patient's head. But here, and hopefully it projects well, you can see channels. So the delay images confirm that this channel actually bypasses that sentinel node, leading to a less intense but nonetheless a sentinel node, which was in the right postauricular region. Similarly, on the left side, you can see separate channels leading down to these two separate sentinel nodes. Here on the delay, when some of the activity is drained, you've got a left postauricular and a left occipital. This is probably second tier. Now you show a surgeon these pictures and they just think squid. You show a surgeon these pictures and they go, oh, okay, so you mean the interval node in the scalp. Two of them, okay, got it. Yes, that's the right-sided occipital sentinel node. They start believing you. Last couple of slides. There's a changing paradigm in melanoma. A large study came out last year called the MSLT2, which followed up melanoma patients that had positive sentinel nodes. And they were randomized into having complete nodal dissection, clear the area that had the nodal metastases, or just watching them with ultrasound. A bit of a paradigm shift, because up until this point it had thought to be the gold standard to clear the nodal basin if the sentinel node is involved. But what they found was that there was no difference in overall survival. In other words, there's a proportion of patients that will just have sentinel node involvement and no other nodes in that lymph node field. And the paradigm is changing to try and choose those patients that you can avoid clearing the nodal basin and subjecting them to possible side effects like lymphedema. And that's what means we have to be very vigilant with accurate sentinel node mapping. This is a patient that had a melanoma close to the sternum, and accurate mapping showed 3 sentinel nodes, 2 in the sternal region and 1 in the supraclavicular region on the left side. Surgeons sometimes like these images to help them procure them. In this case, the sentinel nodes were just observed because it was quite a thin melanoma. SPECT-CT localises that lateral supraclavicular sentinel node, and one that is very close to the injection site, such that SPECT-CT finds it difficult to localise it. Remember, SPECT has good contrast resolution, but not necessarily better spatial resolution compared to a high-quality planar image, getting the camera as close as you can. I feel silly saying that in the technologist track. This was the sentinel node in the suprasternal notch at baseline. It was a patient that had a very thin melanoma. They left it alone. At follow-up, it enlarged, and the biopsy proved to be early recurrence. The patient went on to have retrieval of those surgically. So clearly, without accurate mapping, you're going to miss these cases of early recurrence, and after all, that's what it comes down to with melanoma. Picking them up early so they can be surgically managed and prevent dissemination of metastases. I haven't talked about these other agents that you've probably heard about, Lymphoseek, tilmanocept, receptor agents, which have been sold as having greater retention in the sentinel nodes with less flow through to second tier nodes. Watch your space on that. But I would like to highlight that accurate mapping, including SPECT-CT, is vital, particularly in this changing paradigm in melanoma patients where there's a shift towards less invasive surgery. Thank you.
Do we have any questions for Dr. London? Apparently no. All right, thank you. All right, and last but certainly not least is Dr. Elizabeth Bailey to the stage to talk about new applications in VQ lung imaging.
Thanks, David. I always seem to get the VQ SPECT presentation, so I apologise to those in the room that may have already heard some of this for the last 3 years. However, what I've tried to do is we've tried to take a new slant on it. So rather than thinking about the way that we traditionally do lung scanning, which is usually for PE, have a look and see what else you can do with a good old lung scan. It's been around a really long time, as you'll see from my first slide. It's been around since 1964. And there's been quite a few shifts in changes to do with ventilation agents. and the way that we acquire the data. So I'll quickly go through that initially. But it's more importantly, some of these old tests can actually be used in new ways for new clinical indications and using some of the fancy software algorithms that we have these days. So it's always nice to keep in mind these old techniques, even though they may be a bit of a dying trade for PE. I'm sure we all know that CTPA is taking over a lot of the PE work. The good old lung scan can be used for all sorts of other things. And that's kind of what I'd like to focus on today. However, just be aware that there have been a lot of changes over the years. Certainly in Australia, Xenon and Krypton, even in my very long career in nuclear medicine of more than 20 years, have never been available in Australia. However, I know in the US and in certainly other countries of the world, Xenon and Krypton are routinely used for imaging. And in a lot of ways, they're actually better for imaging airways disease than some of the ones that we actually use these days, which are the aerosols and technigas, in that the way that they actually are taken up in the lungs is a better mimic of physiological status of ventilation within the lung fields. They're certainly the way you should go if you're looking for clearance studies. However, most of us will use aerosols or will use technigas. So if you happen to be in Australia, in the UK, in certain areas within Europe and throughout Asia Pacific, you have access to technigas. Otherwise, you can certainly use the aerosols. Now, the big advantage of technigas over aerosols is the way that it's distributed through the lungs, the fact that it's actually an ultrafine particle. You certainly have less issues with central airways deposition, and allows you a better peripheral deposition of the product, so to allow you to look at overall ventilation to the entire lung fields. Now, VQ scanning has always been planar. Until many years ago, when we started to shift towards moving from planar imaging to 3D imaging, and I think you've heard a few presentations in this session alone about the utility of SPECT-CT. Pete gave a great talk on using whole body SPECT-CT, dynamic SPECT. Kevin's clearly identified that SPECT-CT is an integral part of sentinel node imaging. We can potentially look at using dynamic SPECT for renal imaging. For VQ imaging many years ago, we moved over, a lot of facilities moved over to SPECT-CT. I use the example of these days you wouldn't do a chest x-ray, you'd do a CT if you were looking for fine detail. So it's kind of moving from that 2D planar world to the 3D world if you have the capacity to do it. And it's actually relatively simple. And there are an awful lot of advantages in moving over to SPECT. Besides the fact that you actually get 3D resolution, you get better spatial and contrast resolution, you certainly get better diagnostic accuracy and higher sensitivity and specificity with using SPECT as opposed to CT. You can pick up much smaller defects, and you can certainly see lobes that you cannot see on 2D planar imaging. So the medial lobe is certainly one that you will only ever see on SPECT. You cannot identify it on 2D planar imaging. And these publications are old. They've been around for many years. The published literature that talks about the comparison of SPECT data to planar data, that data is clearly identified. Oops, my apologies. That SPECT is far superior in most instances, and in fact, in a lot of instances, has some benefits over CTPA. So in our department, if you're talking about PE for our campus, everyone should have a chest x-ray, because if your chest x-ray shows a lot of abnormalities, then in reality it's most probably more beneficial to do a CTPA. So if there's a lot of consolidation, if there's pleural effusions, there's all sorts of anatomical abnormalities, a CTPA is most likely more beneficial to you because the cause may not be PE. If, however, their chest x-ray is normal, and they are not a 20-year-old female that they're concerned about all sorts of radiation exposure, they will send them to us for a SPECT, and we routinely do a CT in all patients unless there are age factors involved. So obviously we would reconsider it in a 20-year-old female or in young females as well. Now, the nice thing with having the access to 3D data is that you can do things like correct for this horrible central airways deposition, and this is actually with technigas. There's an increased prevalence of asthma and certainly COPD out there in the world, And when you've got patients that have problems with their airways, you can get clumping of the ventilation agent within the airways. Now, that can actually preclude your ability to actually interpret the perfusion data because these counts are still present in your perfusion data. Now, if you have a 3D data set, you can actually subtract this data from your perfusion data and get true perfusion counts. And this will assist you to identify any small abnormalities in your perfusion data. It also then allows you to do fancy things like look at VQ ratios. So this is looking, I know this is blaringly obvious. I apologise. I hope everyone in the room can see that that is abnormal because this person is in serious trouble. There's a big chunk out of their lung. But the concepts are that you can use these ratio images to look at small changes between the ventilation and the perfusion. You can do this with a 3D data set. So if you're acquiring spec data, it allows you to do things outside the realm. Now, in this particular patient, it was of no benefit. However, in a patient that has significant airways disease, there's significant clumping of the tracer within the lungs, they're looking for small wedge defects in the periphery of the lungs, then being able to do this type of quantitation may assist our reporting physicians in their clinical interpretation. And it will actually improve the sensitivity, specificity and diagnostic accuracy. So those referrers will actually believe what we're saying. I don't know whether anyone else in the room has ever been told that they work in unclear medicine. But I always say to them, but we're no longer unclear because we're able to use anatomical data and do fancy things and get much better images and we can actually prove to you what we're saying is right. Now, of course, the other nice thing is that if anybody in the room does any work for patients that have lung cancers or other airways disease like emphysema, they want to go in and they want to remove a lobe or a segment of somebody's lungs. They want to make sure that they have enough residual reserve or lung capacity that if they go and remove a lobe or a segment, that patient's airways and their breathing and their ability to live is not compromised. Now, traditionally, we would acquire planar imaging. We would put a box over it. We would split it 3 ways and we get some number that really was not particularly useful. If, however, you acquire SPECT and SPECT-CT data, you can use the CT to actually clearly identify all of the lobes. So you can track the fissures and you can use masks to identify the various lobes within the CT data, then apply that data to the ventilation and the perfusion data and get information about the percentage of ventilation, the percentage of perfusion to those lobes, as well as the volume from the CT data. And that helps to assist the surgeons to understand that if they actually remove a particular lobe, that the patient has enough residual capacity to maintain life, I suppose, because if we can't breathe, then that's a bit of a problem. But the SPECT and CT allows you to do this, and it's certainly something that we're increasingly using at North Shore. Now, some other work that we've done for many, many years is we have very good relations with our respiratory medicine department. They do an awful lot of work looking at asthma. Asthma and COPD is a massive issue in our communities, especially COPD. Especially in areas like Asia. So there is a high prevalence of COPD, emphysema within the community. And being able to effectively treat these patients to ensure that they're actually improving their airways is really important. They have difficulties being able to do that. Now, of course, they have all these lovely physiological measures, but the physiological measures are global. So they're not actually looking at individual segments and lobes within the lung. They're just looking at a global measure of lung function. However, the SPECT-CT data will actually allow you to get down to that lobar segmental level to identify areas that may be functioning better or worse than other areas. It also can be used, which is the area that we've been using it for, is to actually look at some of the medications that they have out there and identify whether these medications are working or effectively working or not. Now, one of the studies that we did is we looked at we compared patients, we gave patients something called methacholine Now, methacholine is a medication that they use to diagnose bronchial hypersensitivity. So in patients that have COPD, certain other forms of airways disease, and specifically asthma, they're looking to see which areas of the lung are more sensitive to closure. So basically what we did is we would do a baseline study on these patients. Okay, they were off all their medications. We would then give them a dose of methacholine, and we would repeat the ventilation study only. And I'm pretty sure you can all see that there's significant changes between the two. And the severity of the dropout of the various components of the lung is an indication of the severity of their disease. And the person that actually worked on this, it was one of their PhD projects, was actually able to show that it actually correlated really well with one of their measures of heterogeneity in the spirometry lab. So one of their physiological measures, they were able to correlate against the lobar information we were able to give them from the SPECT-CT data. So this I can't spell either, can I? Multiple breath nitrogen washout test is a test that they use in the laboratories to look at heterogeneity or different breathing patterns within the lungs. It's actually quite a complex test for patients to do. It takes about 30 to 45 minutes for them to do it. The patients at the end of it really feel like they've been hit by a semi-trailer, but it actually correlates very nicely with our changes. And so given that this is a validated gold standard method for assessing heterogeneity in lungs, and we were able to show that in fact SPECT-CT correlated with it, this is a much easier, nicer way for a patient to have their lungs assessed, and it also allows the respiratory physicians to actually look at that lobar level, to look at a particular component of the lungs and say, okay, well, what about if we went and resected that small component of their upper lungs? Would they actually be better off, and would their breathing improve, and would their lifestyle and lung capacity improve? The other thing that we have done some work on is looking at using VQ imaging in patients that are undergoing high-dose radiotherapy to the chest. So obviously radiotherapy has gotten better and better, but one of the big issues is to ensure that they do not give high doses of radiation to normal lung tissue. They can have significant issues with inducing radiation pneumonitis, and radiation pneumonitis, if it is significant enough, can actually cause death. So it's very important that they're able to assess that. So we did a cohort of patients that were going to have high dose. They were lung cancer patients. They were stage 3, stage 4 lung cancer patients. They were being given 60 Gray or more to the chest to treat their lung cancer. We were doing VQ imaging, ventilation and perfusion at baseline at 3 months, 6 months and 12 months after their radiotherapy. And what we were able to do is that we were able to use the CT to map out the lungs. We were also able to then segment them down into the lobar level. We were then able to import the radiotherapy treatment planning fields from our radiation therapy colleagues and divide those planning fields up into various greys, so we could identify areas of the lungs that received low dose as compared to high dose, with the hope that the normal lungs received less than 20 Gray. We were able to overlay the 3-beam radiotherapy treatment fields onto our data and identify which particular lobes and which particular segments within the lungs received different Gray levels to the lungs. And given that we were following them up to 12 months, we were able to look at changes in ventilation and perfusion with time to see if we were able to predict patients that may potentially get radiation pneumonitis as a complication of receiving a high dose to normal lung tissue. It was a very interesting study in that what we showed is that the 3-month study, the lungs actually got worse, which is what you would expect. However, the lungs were relatively resilient, and in majority of patients, the lungs actually compensated. So if the lung that actually got treated dropped out in lung function, the other lobes picked up that remaining capacity, so that in fact the overall lung function remained the same. And in fact, we didn't have any patients that developed significant radiation pneumonitis, which is a good thing. but we were able to identify the amount of dose that was actually given to normal lung tissue. And I think there's a lot more work can be done in this area. I think it's something that we should be looking at because radiation therapy side effects can be very nasty. Now, of course, the latest trend is PET. Everything's PET. There's lots of PET at this meeting. But the nice thing with PET is that the resolution, the contrast resolution, the spatial resolution, everything with PET is far superior to SPECT. That's just inherent in PET systems. However, you can actually easily replace, your ventilation and perfusion agents with gallium-68, okay, and then you can image them on a PET system. The advantage you have also is that you can do respiratory gating on a PET system. Most SPECT systems, I know the newer ones do, but most systems out there in SPECT world don't have respiratory gating, but these systems do. And you can get some really beautiful, beautiful, beautiful images. I don't believe this is ever going to be used for PE investigation, but I would be suggesting that PET is more likely to be used predominantly in the research scenario. So the next study that we're doing in COPD and asthma will actually be using PET. Because we believe that a lot of the issues, especially with asthma, are actually in the really small airways, and that in fact SPECT doesn't have the capacity to resolve those really small airways. So in fact we're going to do our next studies using GalliGas and gallium MAA. And I think that's just inherent in the nature of PET. But you do get some beautiful, exquisite images with the PET tracers out there. And you can do exactly the same thing as you're doing with your SPECT data. So you can identify your lobes, you can get good information on lobar function using the PET tracers as opposed to the SPECT tracers. The nice thing also is that we're actually, in one of the studies we have just done, we've actually gone down to the subsegmental level. So rather than just segmenting the lungs at the lobar level, we've gone one level down, because as part of the study they've actually included a high-dose, high-resolution CT that allows you to identify segments at a much lower level. And so given that it's matched perfectly to the PET scan, you are able to identify changes in ventilation and perfusion at that subsegmental level. So the lung scan isn't dead, I suppose. It might be slightly less in PE. But I believe that we need to think laterally. We need to think about what we can do with the lung scan. There's certainly plenty of applications out there that you can use lung scan imaging for. I do believe that PET is most probably going to expand in use, but I would encourage people to think laterally about what you can do with your lung imaging and continue to do lung scans. Thanks for your time.
All right, so this concludes this session. Again, you only need to scan the QR code once for that. On behalf of the organizing committee, I'd like to thank the speakers for that, and do have certificates for the speakers from the committee. Thank you, and enjoy the rest of your afternoon. Don't forget, there's complimentary tea in the exhibit hall.